I didn't realize that I was like that, even though I spend all my waking hours prescribing medications and doing mental health advocacy. When I worked on it in my own therapy, realized I had internalized a lot of what med school tells you from listening to people like people with mental illness are X, or if I was on medication, I must have been sicker and nobody's going to want to have me as their doctor. All these things are totally invalid, but were in there very deep despite what I was doing. I started talking about it a lot later than I did talking about therapy, but I've been on meds and therapy since college, intermittently in med school where it made sense every time I could in residency with scheduling. I still go every week. I'm still on medicine. I wish we would frame it more like it makes us better people and better at our jobs. I think psychiatry and like mental health programs are slightly better at this because they encourage it as a transference, countertransference thing. In residency, that's something that comes up in psych more than other fields. Like, how did you feel about that patient? Let's talk about it.
Especially in the early applying to residency, anxiety and depression and burnout were the three words that were acceptable, let's say, to use. But then when there are other health conditions, let's give the idea of PTSD. How does leadership take those when they have residents or workers with a known diagnosis?
They're supposed to take it as a accommodation, right? It's a disability just like anything, right? It's carried and covered by the Americans with Disabilities Act. Does that mean we do this super well? No. A lot of our licenses and credentialing forms are asking what count as a legal question. Have you ever in your life ever carried a mental health diagnosis? They're only supposed to legally ask about current impairment, meaning right now, today, in your job, are you going to hurt someone because of what's going on with you? That's the point of that. It's a valid thing to ask, but the way that they have grown to ask it is pretty illegal, but they're state by state boards and state hospital by hospital system credentialing. And they've gotten away with it because nobody's pushed it or sued them or had the money to sue them. And so it is a big issue that hopefully will change some over time.
Hello, everyone. I am honored to interview Dr. Jessi Gold, who is an MD, has a master's, and is the Chief Wellness Officer of the University of Tennessee System and an Associate Professor in the Department of Psychiatry at the University of Tennessee Health Science Center. She works clinically as an outpatient psychiatrist at University Health Service and also writes as a regular expert in the media on mental health. She has been featured in the New York Times, The Atlantic, NPR, PBS NewsHour, The Washington Post, and Self. Her first book, titled How Do You Feel? One Doctor's Search for Humanity in Medicine, will be out in October of 2024 from Simon Elements. Dr. Gold is a graduate of the University of Pennsylvania with a bachelor's and master's in anthropology, the Yale School of Medicine, and the Stanford University Department of Psychiatry, where she served as a chief resident. Welcome, Dr. Gold.
Thanks for having me.
We learned a little bit about all the interesting degrees. Then tell me about you. What brought you into medicine?
Yeah, it's funny, and I don't know how your audience feels about this, but I'm getting used to listening to people read my bio. You do it and you went to these schools, but then they put them together. It's just hard to sit through sometimes because I do feel very different than the stereotype that people might have in their head for the schools that I went to and the things that you read. I think for me, I was probably always going to do medicine. I went to college thinking that I would be pre-med and pretty convinced on that, but really hated the pre-med culture and really hated pre-med classes and tried every day to not keep doing it. But at the same time was like, I've always wanted to do this. These are weed out classes. I just need to do something in parallel and found anthropology basically to survive. Anthropology at its core is a conversation around culture and people. And both of those things were very interesting to me. The medical side of anthropology is like, how did people in medicine, what is the deal with medicine in different cultures? And what does a white coat mean? Things like that, that I wish we learned and continue to learn in school and training, but I think were helpful to me understanding stuff. And I ended up getting a master's because I liked the classes and wanted to take harder, more advanced ones because they sounded interesting. My master's thesis was on pre-med as a culture. So I've always been really into this overlap between things in my own life, training, medicine, and anthropology. Took a year off after college, mostly convinced that I didn't want to take the MCAT while I was in college, but also with this, am I sure this is what I want to do thing? I wish I would have taken more time just because I did spend a lot of that time still applying. It wasn't like I really asked myself that question. If you would have asked like 21-year-old me, I would have told you I took enough time and it was a break and all my friends went right into it. But I really only took that year. I worked in health policy in DC and didn't really give myself a chance to make sure that's what I wanted to do, but I did give myself a chance to learn other things that I thought would be helpful going into medicine. I wanted to understand advocacy more broadly. I wanted to understand policy more broadly. It was right about the time that the Affordable Care Act was coming. So it was helpful to understand what that was going to do to medicine because nobody really knew. And then I'm very interested in the college age group. So I was working on what did it do to transitional age kids because they're not peds and they're not adults. They fit in this in between where they get neglected a lot in these conversations, especially around insurance. So trying to understand that. And then I went to med school. I didn't like a lot of it. I think it was same people, same courses for a while. I survived on good mentors and good conversations with the people I did find that I could relate to. I survived by journaling and writing, and psych was like the only, and you'll hear this a lot from people when you're in psych residency. It was like the only like area where I was like, I guess I could do this. Like it wasn't even, oh my God, I'm in love with psych, but it was like, out of all of the specialties, psych felt like I could fit the most and find a way within it. It felt like people still had time for patients, and it was like you could still sit and listen. It felt like I could see 100 patients with depression, and I would be interested in the way that they got depressed, even if the thing that I did was the same. So maybe they all got the same med or class of meds at the end, and that would feel boring to someone. The rest of it was still important. And that was helpful at like sort of me distinguishing between psych and other fields. And then ultimately, psych is about storytelling, and so was anthropology. It ended up making a lot of sense. If you would have asked me applying to residency, I would have said, my mentor's a psychiatrist. I tried not to be one because my dad is one. I think I fit best in here because people do weird stuff and they're still psychiatrists. It was the only field where people were writing and advocating, and some of that is time and the ability to have a pretty flex schedule in a psych field in a lot of settings. But it was a place where I saw different models of being a physician. I just knew I could never do 100% patient care and that some of this other stuff needed to be part of what I was doing. And so, like, psych just felt like the catch-all for in a lot of ways. I feel like people listening are probably like, "She doesn't like psychiatry." I actually fell in love with the content and the things that we were doing more over residency than I did in med school. We just didn't have the time in med school. Med school, it's like a trick, and they just wanna know if you can decide what you wanna do for the rest of your life in a month. I did 2 months because I did an extra one as a 4th year. All of a sudden, you've done something for 2 months, and that's what you're gonna do for your life. For me, it was like, this is the best fit. I couldn't have told you it would be a great fit or not. I liked patient care and residency much more than I would have ever imagined, and I liked mental health and fitting all of this within mental health much more than I would have thought. It didn't make sense to me as the place that I fit until I was that far along. I could drop out along the way and change my mind and do something else, right? But I didn't, and as a result, found my place within it. And I think it's worked out that way. That was a long-worded answer to your question.
No, it wasn't at all. That's really helpful to hear that progression. It's comforting to hear, even though I already chose psychiatry. But if I go backwards, even a year ago, it's really comforting to hear that it gets better and that you don't have to be like, this is exactly my specialty. This is exactly what I'm going to do. It's okay to be unsure and still fake it till you make it and until you actually like really find yourself. I connected with that because I was between family medicine and psych, but it was that mental health component. Like you said, the more time with patients, the just storytelling, which I love.
Yeah, I think it's interesting that you say committing and things like that. Like But with the way we do med school in this country and the kind of competition and the pre-requirements and stuff like that, it makes you feel like you have no time to question it. I think that's really dangerous. What I said about taking a year off and thinking that was awesome was when I applied, it just wasn't a common thing. They had started doing post-bac programs. My sister did one, but those were for people who like had a 100% change of career. It wasn't really for people who just took some time and tried to figure it out. It was like people who my sister worked in economics and then became a doctor, right? It's people who had very full life changes. For me, having the pauses or being able to question that is critical because otherwise you end up like you're 30 and you've been in school the whole time and you're all of a sudden doing this field and it doesn't fit and you never asked yourself about it. That's hard, and that can lead to some people being sad later in this training. We don't have a lot of time to question it, and it's almost seen as this unspoken thing that you're just supposed to know and figure out because you're already here. There were times in med school where I was like, "I don't wanna do this," and the reaction from people was like, "Who gets into Yale Medical? You should stay and get the degree," right? It was an honor and privilege for me to be there as opposed to still it doesn't matter if I don't wanna do it, right? I think the way we view this stuff is a little messy. I hope that it's gonna change with people like me in leadership, also the way Gen Z kind of thinks about mental health and the way that it fits their life. I feel like they question everything, which can be challenging probably for older people, but I think it's good in a lot of ways because it challenges us to say, yeah, why do we do it that way? If we don't have a good answer, that's probably not the right way to do it.
That is really helpful. I'm wondering, from your experience, what specific types of questions should people be asking themselves before they make the commitment or even while they're still in residency and still going through their path?
It's hard to know the exact question. I had a therapist once make me write down all of the careers that you could possibly do and go one by one and tell her why I didn't want to do it. I was still pretty myopic, just as a this is what I'm going to do. And I was probably less self reflective than I could have been if I did that now. I think it was a helpful exercise to realize there are other careers. A lot of it comes from family, a lot of it comes from culture, a lot of it comes from prestige, a lot of it comes from value in society. You need to step out of that and be like, what is it about this that I like? What gets me out of bed in the morning? And what am I hoping? What are my strengths? And does this career align with that? What are my values? And does this career align with that? Some of that might require psychotherapy, but you might be able to get it in your college or med school for free. So it might be worth doing. But to be able to say, these are the things I value. Does medicine value that? And is the reason that it doesn't because it could never change? Because then you're going to have a hard time fitting a circle in a square. Some things about medicine are slowly changing, but some things are not or will change way slower. And I think then it makes it not a perfect field for everybody. So you want to ask, what are my values? What gets me out of bed in the morning? Am I doing this for me? Sometimes when I look back, I'll say, I don't know. I have no idea how I got here, but I'm here, right? But I never was like, is it because external forces got in my head and without them, would I have the same opinion? So I think you need to, as early as you can as a self reflective human, try to tease apart the other influences and figure out your actual feelings about it. If you make the decision not to do it, that it won't be impossible because there might still be external influences that are making you feel like that's the only choice. But if you make it at 19 instead of 30, you're going to be a lot happier about it.
Those are amazing suggestions, and I'll make sure to list them out because I think that it's really helpful to have those specific things. Talking about what are your values, I think is a big thing. Actually, when I was applying to residency, I had that question come up. It was really helpful because that's how I was able to align with programs that had similar values to my own, which is nice.
Such a psych question. And there's so many things that if you interviewed for psych residency, only psych people would ever ask you, and that is such a psych question. It's hilarious.
Oh my goodness, yes. And definitely that was the most fun questions is just discussing with another psychiatrist about those types of things, about who we are as humans, why we do what we do instead of just the CV. You said something that caught my interest, especially now that you're in a leadership position. And it sounded like that through your time, you were learning how to push barriers. As a future leader myself that also pushes barriers, sometimes a little too far, do you have advice for us on how to work with leaders in medicine? Maybe that's in our residency or in our future career when you believe something could be pushed or changed a little bit, but there is that older generation or just the rules or things had been as they are because they exist.
Yeah. When I was younger, I cared a lot about the way I was perceived and what that meant about my academics or success as a human. In med school, when I got like negative feedback or something about what you would consider maybe one of my strengths as a human, sort of like pushing or being a little outside the box or thinking hierarchy is stupid, I would take that to heart. I would cry. I would be very upset and want to change myself or try to fit into what they wanted to get into residency and survive med school, right? And I think that was somewhat right in that sometimes you need to figure out the balance of survival and pushing. But as you get older, the pushing can outweigh the survival part because you're able to do that, right? So hierarchy is stupid, but it exists. And as a result, you have to figure out somehow to adapt within it. Medical culture is stupid, but it exists and it's not changing tomorrow. You have to have the dialectical perspective around it, which is med school is challenging and there are things I want to change. Medical school has hierarchy and stress that I don't like, but I still want to be a doctor. Having that balance is something you carry with you to be like, medical culture is challenging and I'm burning out, but I don't want to quit. Quitting is valid and I will put that out there, but sometimes we get lost in these things that are really making us mad and and we can't, sometimes we just don't have that power to change them. That's miserable, but eventually you might be able to get the power. And it's like which battles are worth fighting and when, if that makes sense. So like when I was younger, I wish I was better at not taking that stuff to heart and accepting it as a product of the culture and that I needed to, it was a means to an end. This person is not great person. I'm not a bad person. And I don't think I was able to pull it apart when I was younger. As I got older, a lot of my work has been in this stuff, which has been like, let's talk about questioning. Let's talk about our own well being. Like, what's going on there? I started doing research in it. I tried to start doing like med school. We did med school support groups for med students as psych residents and learned psych group therapy that way. So I set up this whole program. And that way we could get like education back, but also support. And so a lot of the stuff that I started doing was like, how do I do both things? Like, how do I fit in this system, but start to think about why it's this way and change it as I can. But I think as you get further along and you're more able to make these choices and people start listening because you do make sense, it feels better, right? It's all picking your battles at the right time, maybe. I think there definitely are still rooms where I'm younger than a lot of the people and people might be like, what is this young whippersnapper saying? But I've gotten to the point where it's, you think I'm young and I'm still right. And so I think that you just get there. What I would say to a younger person is don't get frustrated with the weeds because you can cut them later. If it's unsafe, if it's dangerous, those are all things that are worth speaking up about when you're in the moment as much as you can. Medical culture is complicated. I was like, had medical bullying and all that kind of stuff in my residency and earlier on, I guess, in med school. My residency was actually not like that really. And I think that wasn't great, and I spoke up about it at the time and probably would have gotten a better reception in today's culture for speaking up about it, but I think there are some things where you have no choice and it's the right thing to do, but if there are things where it's like, "It would be better if," but I've tried and I keep running into this and it's just taking a lot of energy and emotional exhaustion, and I know it could be better, but no one's listening to me about how it could be better. You might need to find a place that will listen, and it might be a little bit of time. There have been times now that people don't think I'm that serious. Right now, I'm wearing a mental health t-shirt with a jacket and pants, and
Artist,
it's basic.
your feelings deserve to take up space. I mean, that.
So I started doing talks. I gave a talk before we met today. I started doing talks in this kind of year. Would you call that academic? No, but can you tell me I can't wear a mental health shirt to give a mental health talk with a suit on? Probably not. And is it now my brand? Yep, there's not much they can do about it. I think you push things where you want to push them and figure out where you fit. Sometimes it's easier to do that when you're past the point of it being so much about applications and competition. You might need to get a little further along and finish things before you get into all the fights. I always say it's worth a try. Some places you're just gonna butt up against stuff for a really long time. It's gonna hurt you more than it would hurt them. They don't care.
No, that is a hard lesson that I'm learning. And you're totally right. It's been so important to actually, my therapist said something similar of when is it important? When can you actually do something versus letting it go and letting that battle happen to some other time or for another person. It's been an important thing to learn for sure.
Yeah.
I know in your book
Yeah.
that I'm excited about that you experienced your own emotional struggles during your education. Can you talk a little bit about the different struggles or challenges that you had?
Sure. The interesting thing is that it's somehow novel for me to have this conversation, which says a lot about where we are in our culture and how much we do need to change. I think going back to the last conversation, sometimes we have these big goals, but sometimes the smallest thing would still change things, right? It would be different in our culture if some of us had these conversations, if some of us were honest that medical school is hard. Some of these things you just start peeling back. It seems really simple, but me having these conversations to whoever hears this, or when I'm giving talks, like casually mentioning my therapist, is a way to break it down. And it's not like I'm having an edict and changed all the rules, but you can slowly do it that way too. So somehow this is novel, and I'm happy to be one of these people that does this, and not a lot of people do. I struggled in college for a lot of the reasons I mentioned. I never didn't get A's, and I didn't know what to do with it, and I didn't like the people. I was used to having peers in classes, and I could always find, I would say, the normal pre-meds, but they kept dropping out, hence my culture conversation on my thesis. If everybody that is like me is dropping out, maybe there's either something wrong or I shouldn't be doing this. And so you got in this identity issue, and then you're like a junior and it's hard and you're trying to figure it out. I ended up probably later than it needed to be in the counseling office in college. I told my story to the counselor on campus, and they told me I wasn't sick enough to get care there. That's the way I remember it. I bet if you asked the person, they would say they didn't say that exact thing to me, but it felt interesting because on the one hand, I didn't want to have problems. And so it was moderately validating that my avoidance was correct. And then on the other hand, it was like it took a lot of time for me to get there, and it was just unhelpful. They said go off campus. I did. I didn't like my off campus person right away. It took a bit of finding somebody that I fit with to understand that I had enough to talk about and my feelings and experiences were valid. I think that because of social, which wasn't the case when I was younger, because of social, people share a lot of things that kind of feel like trauma dumping. And so you might feel like your problems don't matter, or as a clinician, you might listen to people who've had worse lives and think my life isn't like that. I don't deserve that. And truthfully, like the worst thing you're struggling from is your thing. And so you should always think like that. I think with that, I started to be like, maybe these aren't real things and they don't matter. I had to have a good therapist that was like, there aren't good or bad problems, and valid or not, that's not a thing. I also started medication at the time. I went on Wellbutrin. I've been on Wellbutrin since then. No dose change, nothing. The first time I talked about being on meds was significantly later than I talked about going to therapy, because I don't think we're as comfortable talking about medication. I didn't realize that I was like that, even though I spend all my waking hours prescribing medications and doing mental health advocacy. When I worked on it in my own therapy, realized I had internalized a lot of what med school tells you from listening to people, like people with mental illness are X, or if I was on medication, I must have been sicker and nobody's going to want to have me as their doctor. All these things are totally invalid, but were very deep despite what I was doing. I started talking about it a lot later than I did talking about therapy, but I've been on meds and therapy since college, intermittently in med school where it made sense, every time I could in residency with scheduling. Nights were sometimes harder. I still go every week. I'm still on medicine. I wish we would frame it more like it makes us better people and better at our jobs. I think psychiatry, and you'll realize this, and like mental health programs are slightly better at this because they encourage it as a transference, countertransference thing, which for anybody listening that doesn't know what that means, I might be feeling something based on something a patient said that has nothing to do with the patient, but has to do with my own stuff. But if I don't try to figure that out, I'm not going to know what that feeling's about, and that might interfere with care. In residency, that's something that comes up in psych more than other fields. Like, how did you feel about that patient? Let's talk about it. I think we frame at least even those conversations in a supervisory perspective, if not going to therapy, a bit more like a growth opportunity and a way to be better. I don't know that it is framed like that. I think it's seen more as a crisis, like you need it now, you're sick, which is way I saw it in college, which was like, I'm not doing okay, I need help now. It wasn't like, you're starting to not like this and you're questioning your identity around medicine. Maybe you should talk now because it's framed as a targeted intervention for later. It makes it harder to see that you could have benefited earlier or that you can still benefit from it. Like, I still go weekly, right? When people think about how often people go to psychotherapy, weekly probably sounds like I have things to talk about every week and I'm struggling every week. I'm not, but it helps a lot with my job and what I listen to and processing it. Watching some of the stuff that she does and models teaches me how to be better at my job, which is super cool. The other thing that I really struggle with is burnout. When we talk about burnout, it's used colloquially wrong, like most things in mental health, but burnout's really like this constellation of emotional exhaustion, depersonalization or cynicism, meaning you're just really disconnected, and then decreased sense of personal accomplishment. I most experienced that at 6 to 12 months in the pandemic, was doing virtual psychiatry and never had trained even once doing a video session, which is gonna be so different than anybody now, but, like, they didn't I saw it once in a VA, but I wasn't a part of it. It was like, look at that fun toy," and I'm not even that old. Like, I graduated residency in 2018. It just wasn't a thing, and that's how fast technology had to change because of the pandemic, just so people listening understand, which is good and bad and complicated, right? But so I wasn't used to it. I'm a person who did this for the stories and the people and the humans, and I'm stuck at home in front of my computer. All my patients are healthcare workers, which is a whole thing during COVID. And then on top of it, I'm doing outreach and education in our group about healthcare for healthcare workers around the hospital. I'm overextending and I have all this guilt that I'm not an actual frontline worker, even though I'm trained to be and I'm protected by a computer. I need to do more. It was like this whole thing. And so all that compounded to me basically sleeping every day after work for hours and hours. And I was super burnt out. But despite the fact that I could rattle off the definition of burnout and could tell you statistics off the top of my head and probably gave a talk about it, I gave a talk about it today. I didn't identify it in myself. But I think that basically we're very good at looking at other people and not very good at looking at ourselves. In the work that we do, we spend a lot of time on other people and we almost like cease to exist as a human entity in that situation. I just didn't see it. I couldn't understand how that was what was going on with me. And it was like ridiculous when I did. That's something I struggle with and still struggle with and continue to struggle with and have built in things to help around it. But yeah, that's probably not so much the depression stuff. That's been pretty under control since maybe you could say there was a little part in med school, but mostly since med school at least. And so then that just really left me to be burnt out on and off. For people listening, burnout and depression are related but different. Depression is something you can diagnose that is in the diagnostic manual, while burnout is a workplace associated condition and is not in the diagnostic, at least as it exists today. But you can diagnose burnout as a workplace associated condition in the sort of coding to charge that we use that other countries use, but not in psychiatry.
That is so interesting. I was actually going to say, because of burnout, I feel like burnout is a word that people in healthcare are, like you said, throw out, and that's accepted. That word is accepted. You're allowed to take time off if you're burned out. You're allowed to switch jobs if you're burned out. You can't do the same thing if you have a diagnosis that's actually in the DSMs. I'm really glad you talked about that. Do you see it in the future being like an actual DSM term? What do you think?
I
Yeah,
think it depends on who decides that. The diagnostic
true.
manual is all these people get in a room and talk about it. A lot of the people who get in the room and talk about it probably want burnout to stay away from psychiatry a little. I can't speak for them, but I hear the intricate differences in their mind between some of this stuff. I'm not sure that we need to be that specific about some of this, and it might be helpful for it to be in our field because it could be helpful for people, even if we put it in a special classification like the International Classification of Disorders. It's like very specific associated with work, but it's a thing. I think burnout has become an easier thing for people to say. I don't think they necessarily mean as burnt out as I was, but they mean they are tired from work and it's hard and they're not liking it. I've also heard from some people that anxiety and depression are more okay diagnoses to talk about, but the other stuff isn't. And that we've grown maybe from people like me talking about it to being a little more okay with some of these diagnoses. But when you get to a certain level, it's, oh, that person shouldn't see patients or we should reconsider that. I've heard that from patients and friends. Obviously, I don't carry a diagnosis that I would personally be able to speak from that. But from listening, I do think there's validity to that.
I'm really glad you brought that up because you're right, especially in the early applying to residency and things like that. Anxiety and depression and burnout were the three words that were acceptable, let's say, to use. But then when there are other health conditions, let's give the idea of PTSD and working in a VA or with veterans, is that kind of what you mean that it could hinder, or how does leadership take those when they have residents or workers with a known diagnosis?
They're supposed to take it as a accommodation, right? It's a disability just like anything, right? It's carried and covered by the Americans with Disabilities Act. Does that mean we do this super well? No. It's why the main thing that the Lorna Breen Foundation works on is licensing. A lot of our licenses and credentialing forms are asking what count as a legal question. Have you ever in your life ever carried a mental health diagnosis? They're only supposed to legally ask about current impairment, meaning right now, today, in your job, are you going to hurt someone because of what's going on with you? That's the point of that. It's a valid thing to ask, but the way that they have grown to ask it is pretty illegal, but they're state by state boards and state hospital by hospital system credentialing. And they've gotten away with it because nobody's pushed it or sued them or had the money to sue them. And so it is a big issue that hopefully will some over time. The Docs with Disabilities folks do an awesome job having these conversations too, pushing it, putting out really good research on it, which I think matters. As someone who gives these talks, it's very easy for medical people to dismiss the conversation if you don't have research. They don't want the woo stuff. I can teach you skills, but they don't want that. They want you to prove it first. We have a lot of research on burnout. The Docs with Disabilities folks have done a ton of research on what it's looking like with people coming into med school, the fact that people are becoming more comfortable disclosing physical but still not mental disabilities, to think about that more clearly and understand what that is. And have that research makes a difference because unfortunately or fortunately, we're an evidence-based profession. Some of this stuff has to be proven to people for it to change. It is the right way of approaching it, even though it takes some time, because the people in charge still care about that more than a story.
Good point. It shows the importance of why we have to do research and why research is so important for learning and being able to do it. It doesn't just end when you submit your application. Everything in order to progress and actually make change, like you said, we are evidence-based. And I agree, that's so important. I love how you mentioned the licensure because literally today I had a meeting with my doctor about that question. I even pulled up the picture because I was like, question number 59 of the Illinois licensure says, do you now have any disease or conditions that presently limits your ability to perform the essential functions of your profession, including any disease or condition generally regarded as chronic by the medical community, i.e., mental or emotional disease or condition, 2, alcohol or substance abuse, 3, physical disease or condition? yes or no. If you click yes, attach a detailed statement including an explanation whether or not you're currently under treatment. And I love my doctor. She was actually the first doctor that I interviewed here, Dr. Bisgrove. She has a disability herself. So it allowed me to really get her thoughts and what do I do? I'm literally in this process right now. And
That's a legal question. That's a legal question because it's asking now, today, current, and impairment. You can probably say no if you're fine. When it means impairs your ability to do it, it doesn't mean does sometimes you have pain in your leg, does sometimes you need days off. It means because of your mental health condition, are you going to hurt someone? If that helps.
that is actually exactly. And I think she said the same thing. She added in also the fact it unfortunately doesn't ask about accommodations, but that's the thing. If you have accommodations, then you're able to perform essential functions. Thankfully, I'm going to a residency that's very open about that and open about accommodations, but unfortunately, not all programs are. That is definitely another reason why I like to be open and vocal about it because no one talks about it. I myself couldn't even find any information on it.
Yeah, when I started talking about meds, people were like, "Oh no, now you can't lie on licensing forms." And I said, "I don't think I've ever lied." I was like, "I read the question to mean what the question's intended to mean." I don't know that, but the fact that people were like, "Now you're public, you can't lie now," shows you how many people lie because of feeling like those are illegal questions, but not changing them. Like to even have that as a thing is that something that's happening. And then that's bad. And then on top of that, they're like, you're screwed now, right? And so it's interesting. And like, it didn't cross my mind when I wrote about that and started talking about it. It didn't cross my mind because I was like, I am not currently impaired.
Yeah, I hear you. And I hope that's helpful for listeners. Think of it in that way if they're ever faced or looking at those questions. Yeah, I know that there are a lot of organizations, including Docs with Disabilities. I was working with someone at AMWA who's also working to get rid of some. But hopefully in the future, we can work towards eliminating or rewording.
The Lorna Breen folks have a whole toolkit on their website if people want to write people in their state and all that kind of stuff. So if that's like it's just the Lorna Breen Foundation. That's one of their main things. They're making a map of where, in case you're also like, should I move there? What is it like? That could help too. Lorna Breen, LORNABREN.
I got it. Oh, my goodness. So many amazing things we talked about. We could definitely talk for hours, but as we wrap up,
So they're already bored. Hi, everybody. Wake back up. My name is Jessi.
thank you for listening still. But
If you're still listening, I'm still here.
I would love you getting already so much advice, but any pearls of wisdom that you would like to finish with for the audience?
It's very easy to forget that you're included in the equation, especially as you go through training, especially as you get busier, especially as you have other roles and responsibilities, and try not to. Take some time for you, figure out what works for you. Don't do some kind of prescriptive, this is what you do to cope, but figure out what that works like for you, what it looks like for you. Don't beat yourself up about it. Self-compassion is a big thing in our field. We're just not very nice to ourselves because of this competition thing and because they set us up to be like that. Try to hear the way that you talk to yourself and be a little nicer. The world's hard enough. Being a doctor is hard enough. Patients have their own lives that are hard enough. No need to criticize yourself about it too. If you don't end up wanting to go into the field, that's also okay. I like to put that out there for people because there's so many times that we don't question it, and then when you finally do, if it does feel like you wanna question it, that's okay. It's the right thing to be inquisitive about yourself and to care about why you like things and why you don't like things and what about it you like, and it's okay to put yourself first in some situations. I think hopefully we'll create a workplace that's better in the future, but culture change takes time, big institutional change takes time, and you just know that the way I think about wellness is like, how do you get through that? And so it's not about resiliency, but it's because our resilience is higher than other groups. But this is the way that it is. How do you deal with the way that it is right now? And at the same time, ask for and advocate for the things that you want to change and try to get in the positions that you can't. It takes a while. I'm an impatient person and I'm young and in a big role, and it took a while still in my mind. I've always known that I'm a systems thinker and a person who look at something and tell you what's broken about it and how to fix it. But sometimes you can't. You have to let it go and get to a place that you can do it and try to get into the rooms where, to quote Hamilton, where the rooms where it happens, right? I think in a lot of ways it takes a little patience, but you can get there. And it does matter that you're in those rooms and that those rooms start to look like the patients we take care of. And hopefully people will stay that will make a difference and they won't all quit because that would be sad to me.
I love that comparison to make the room look like the patients we care about. I've never heard it like that. And I love that. That's exactly the point. We are their advocates. We want to share their voices and we want to help them. We can't help them if we can't also help ourselves. Dr. Gold, thank you so much. I always
Yeah.
like to do a quick summary of all the amazing things you said, starting with going in college, you were passionate in pre-med, but you found your passion in anthropology, culture, and people. That's how you did your own pre-med journey, getting a master's and still unsure, but still going the path of medicine. Took a gap year, worked in health policy, really helped you get a broader view of medicine and how it impacts individuals through medical school. Something that really helped you was journaling and writing to understand the pre-med culture that's in medical school, the competitiveness. It really helped for you to look at yourself and see, why am I doing? What do I enjoy? And follow that path. Even though you weren't 100% on psychiatry when you started residency, it was okay. Because once you got in there, you found your passion and you really started to find your own little subspecialty and connected your values through wellness and supporting other residents through support groups, which I'm sure was helpful, and being open about your own struggle, because only when we share, other people can too. You also provided some specific questions people should ask themselves. What are your strengths? Am I doing this for me? You also talked about how, as future leaders, how we can make little changes, but recognizing that there is a hierarchy in medicine and it's not okay, but it exists and we have to live in it. There are little things we can do, but we have to choose the battles we fight. And you also talked about your challenges in mental health and how helpful it is to be able to get to where you are today is taking care of yourself, seeing a therapist, getting medication, but taking care of your own mental health to support your patients and do a better job. We talked about burnout and to finish off, advice on self-compassion and being okay when your journey is different than you originally planned or different than others. So hopefully, okay, summary.
Yeah, it's a hard thing to do. Summarizing is a skill you learn in psychiatry training, so you'll only get better. Have you ever noticed that I don't know how much you saw of outpatient psychiatry, but for people listening for therapy and stuff too, sometimes when you're talking to someone, they go, "So what I'm hearing you say is when this happened, am I hearing that correctly?" And sometimes that is because when you reflect things back to people, they hear things differently. And sometimes it's just making sure you understood. But really, it's like kind of an emphasis in making sure that you're telling that person's story the way that they want it told, right? And the way that they hear it being told. And so it is a skill in psychotherapy to summarize and reflect. So you'll just get better at that, I think.
I'm so excited. That is definitely something that I'm most passionate is psychotherapy. So that is my next goal. And I'm doing low practicing. I like it. If individuals would like to get in contact with you, can you share some ways they can, or also your book, of course?
Yeah, absolutely. I'm at Dr. Jessi Gold, basically on most platforms. I spelled Jessie annoyingly like Jessica without the CA because that's how I felt as a kid. So Jesi, Dr. Jessi Gold across platforms. My website's also Dr. Jessi Gold. It has a contact form. If you write me through there, I'll get it. If you want to have me come for a talk or grand rounds or your group or whatever, that would be the place to get me. And then, yeah, I'm super excited. I've been a short form writer since med school, but never written a huge thing. It's part memoir, part patient narrative, and really looks at this kind of content, what it's like to do fields where you care for other people before you care for yourself and how to find yourself within that. And I think people like it. You mentioned the title. It's How Do You Feel? One Doctor Search for Humanity in Medicine. And you could get that. I'm sure you'll link it, but there's a Simon Schuster webpage for it. Order it now and Pre-orders are really big for authors, especially first-time authors, just because it, like, helps people know that, like, you're interested in this content. It would be really awesome if people listening were interested in this content and did buy the book, even though I know that's a hard thing to do financially, but it just solidifies the importance of this content to other people too if you support it. I do think if you felt validated by anything they said, you would feel validated by the whole thing.
Beautiful. I already added it to my book list. I have a book list on my website from Bookshop, and I put it in the mental health section, in living with disabilities section. I'm very excited to read it. Do you know if you'll be doing an audiobook of it? Like you'll be reading?
I don't know all those details yet, but there will be an audiobook. I'm not 100% sure if I'm the voice, but I'll find out sometime soon.
Definitely let me know because I'll be doing hour commutes to my residency. So like I'm already stacking up all these audiobooks. I want to make sure you're on there.
Awesome. There'll definitely be an audiobook.
Something to think about. There's just something so special when you hear the author read their words because sometimes they add in their own other things. That's the reason why I started this podcast because I wanted to make an audio of my blog posts. And then, yeah, all this created.
But I totally get that. It's really interestingly complicated.
Yes. Thank you so much, Dr. Gold. And I hope to see everyone next time. Take care.
Yeah, thanks for having me. I get to talk about it today. I didn't identify it in myself. I don't know why I just did that. I hate when it does that, but I just did not give you a thumbs up with my hand, but this Zoom did it. So sorry to everyone listening by my distraction from my thumbs up.